Hello. In this video we talk about thyroid hormones and anti-thyroid drugs. Okay, we will start with quick physiological review of thyroid. The thyroid produces approximately 90% inactive thyroid hormone or thyroxine and 10% active thyroid hormone or triiodothyronine. Thyroid hormones are lipophilic, cross blood-brain barrier and placenta. They bound to transport proteins and only a small fraction are free and active. Thyroxine is a prohormone. After entering the cell it is converted to triiodothyronine which binds to thyroid hormone nuclear receptor, increases transcription of genes involved in the following cellular functions: stimulation of metabolism, promotion of normal growth and maturation, particularly of the central nervous system and skeleton, sensitization to the effects of catecholamines, so increase heart rate, stroke volume and induce sweating, anxiety, and tremor. After the simple physiological review, let's start with hypothyroidism. Hypothyroidism is a common condition with various causes, but autoimmune disease, thyroid failure following radioactive iodine or surgical treatment of thyrotoxicosis, account for over 90% of cases. Hypothyroidism is treated by thyroid hormones replacement. There are three synthetic preparations of thyroid hormone: levothyroxine T4, liothyronine T3, liodrix T4 and T3. We will make simple comparison between levothyroxine and liothyronine. Levothyroxine replaces normal serum levels of T4 and T4 is converted peripherally to T3. Liothyronine replaces T3. Levothyroxine absorbed orally well, but its absorption is affected by presence of GI ton content, so take it 30 minutes to 1 hour before breakfast on empty stomach. Liothyronine is absorbed orally well and not affected by presence of GI ton content. But both cannot be absorbed in case of myxedema coma. Levothyroxine has long half-life which permits once daily administration. But liothyronine has shorter half-life, require multiple daily doses, and has rapid action 3 to 4 times more potent than levothyroxine and consequent greater risk of cardiotoxicity. After talking about the thyroid hormone preparations and compare between them, let's talk about management of special cases of hypothyroidism. First, myxedema with coronary artery disease. As we know, the low level of thyroid hormone in these patients protects their hearts from angina pectoris, so correction of hypothyroidism must be done cautiously to avoid provoking arrhythmia, angina, or acute MI. If coronary surgery is indicated, it should be done prior to hypothyroidism correction. Second case, myxedema coma, end state of untreated hypothyroidism which is medical emergency. The treatment of choice is to give a loading dose of levothyroxine intravenously. We can also use intravenous liothyronine, but it may be more cardiotoxic and more difficult to monitor. Keep in mind, if the patient has associated adrenal or pituitary insufficiency, intravenous hydrocortisone is indicated. Third case, in pregnant hypothyroid patient receiving thyroxine, an increase in thyroxine dose is required because early development of the fetal brain depends on maternal thyroxine. The second part of this video is about anti-thyroid drugs used for hyperthyroidism. Anti-thyroid drugs are thiamides, iodide, radioactive iodine, anion inhibitors, and beta blockers. To understand mechanism of anti-thyroid drugs, we firstly talk about steps of synthesis and release of thyroid hormones. First step is the transport of iodide into the thyroid gland by sodium iodide synthase. This can be inhibited by anions. Second step, the iodide is oxidized by thyroidal peroxidase to iodine which rapidly iodinate to tyrosine residues within thyroglobulin, in organification process to form monoiodotyrosine and diiodotyrosine. Thyroidal peroxidase is transiently blocked by high levels of intrathyroidal iodide, and blocked more persistently by thiamide. Then two molecules of diiodotyrosine combine to form thyroxine, and one molecule of monoiodotyrosine with diiodotyrosine to form triiodothiamine. Finally released by exocytosis and proteolysis of thyroglobulin. This process is also blocked by high levels of intrathyroidal iodide. Now start with first and the most important group. Thiamide. Include methimazole, propylthiouracil, and carbimazole, which is a prodrug of methimazole. The major action of them is to inhibit thyroidal peroxidase. This means that they inhibit the synthesis rather than the release of the hormones, so the onset of their effect is slow, requiring 3 to 4 weeks before stores of T4 are depleted. However, propylthiouracil also inhibits the peripheral deiodination of T4 to T3, so can be used for rapid improvement. Let's make quick comparison between methimazole and propylthiouracil. Methimazole is more potent, lesser bind to plasma protein, so higher across the placenta and not used in pregnant women. Methimazole has long duration, so used once daily. In other hand, propylthiouracil is less potent, but with higher bind to plasma protein, so less cross the placenta, and is preferable during first trimester of pregnancy. Propylthiouracil has short duration. The most common adverse effect of thiamides is maculopapular pruritic rash. And the most dangerous adverse effect is the granulocytosis. Second group, iodide such as Lugol solution and potassium iodide. This group inhibit organoification and inhibit thyroglobulin proteolysis, so block the release of hormones. It also decrease the size and vascularity of the hyperplastic gland. According to the actions of this group, we can conclude its clinical use. Okay, we said it inhibit the release of the hormones, that mean it has rapid action to improve thyrotoxic symptoms, so used for thyroid strom. And it decrease size and vasculature of the gland, so it is valuable as preoperative preparation before thyroidectomy surgery. However, keep in your mind that thyroid gland will escape from the iodide block in 2 to 8 weeks. The adverse effects are rare and in most cases reversible upon discontinuous. They include acneiform rash, swollen salivary glands, mucous membrane irritation and ulceration, and metallic taste. The third group is radioactive iodine. Its action depends on emission of beta rays, which with a few weeks destruct thyroid parenchyma. Advantages of this group include easy oral administration, effectiveness, low expense, and absence of pain, so it has largely replaced surgery in the treatment of hyperthyroidism. But it is contraindicated in pregnant and lactating women, since it cross the placenta and excreted in breast milk, lead to destroy the fetal thyroid gland. Fourth group, anion inhibitors as perchlorate, which block uptake of iodide. The major clinical use for perchlorate is in patients with iodide-induced hyperthyroidism, as amiodarone-induced hyperthyroidism. Last group, beta blockers, which cause clinical improvement of hyperthyroidism symptoms, but do not alter thyroid hormone levels. Propranolol at high dose may also inhibit the peripheral conversion of T4 to T3. Thanks for watching.